Sorry for frequent show up because of my aeroplane timing. That's why they put my agenda tight. Thank you, Novo, for inviting me for this session. Of course, all of you كل سنة وانتم طيبين for رمضان. إن شاء الله ربنا يعني يبلغنا رمضان جميعا. كل الأدوية في رمضان لها سيستم، وكل حاجة لها سيستم، وكل حاجة لازم نبقى عارفينها. ايه الأدوية اللي نستخدمها في رمضان، وايه الأدوية اللي نقللها في رمضان، وميعاد الأخدان، بس ده مش موضوعنا. لكن our topic is ما أنا I will دكتور مصباح asking me to talk in English. I told all the audience to take it in English. How to use the Ryzodeg asp. The Ryzodeg asp يعني 2 to 3 years now in the Egyptian market. Of course, we know that Muslims constitute a lot of our universe. Of course, we have obligation to know how to fast Ramadan. This is one of study in the MENA region that I share it, and we have noticed that most of our diabetic Muslim fast Ramadan. Most of them. You see those in blue color in the Ramadan prospective study that I share. Those who fasted 15 days in the blue column, and the red column who fasted every day. Also the Creed study, Dr. Abdul Jabbar, who done it, 94% more than 15 days, most of them every day. That's why we facing a new era that in the past we ask that type 1 diabetes we must not fast, and the type 2 avoid to fast, but now we are facing the reality. Hypoglycemia, hyperglycemia, diabetic keto, and the dehydration and thrombosis tendency are the most 4 risk factor in diabetic who fast Ramadan. Even if he found him hypoglycemia, you face it in your family, something like that, or in your relative that who diabetic patient who even feel fast and 1 hour waiting for the adhan, he insists to continue. Sometimes he go to sleep. And they say this 1 hour doesn't differ. I am in hypoglycemia, but in 1 hour it go through. The insulin injection, of course, the type 2 diabetes on using insulin carry risk of hypoglycemia because it's a complex issue, and we must educate our patient and individualize them. A case again like Professor Misbah bring, Mr. Murad. So the cases make us more practical. Age 55 years old, 10 years of diabetes, average weight. His A1C is not controlled at all. His postprandial slightly elevated. He is office worker, intolerant to GLP-1 medication, and different scheduled every day, non-compliant to medication, because the last 2 is very, very important in our patient. Different schedule, sometimes eat in different lunch time, non-compliant at all. Intended to fast Ramadan, fear of hypoglycemia. So we have 4 criteria in this patient. Using glargine U130 unit at night, they have sodium glucose transporter metformin, and they have one of the DPP-4 inhibitors. So he have a good therapy, long-acting insulin. He has sodium glucose. He has DPP-4 inhibitor. This is his blood glucose monitoring or self-blood glucose monitoring. We face the red column or red color that the post-lunch is very, very high, and the difference between pre-lunch and post-lunch is very high, at least translated into A1C very high. We have postprandial hyperglycemia. He have afraid of hypoglycemia. We need a patient more compliance and more flexible regimen. So we have choice: add prandial insulin to his lunch, switch to the pre-mixed insulin conventional or analogs, or using the Ryzodeg asp, the newcomer of the complex insulin or mixed insulin analog, which is contain Ryzodeg and asp, 30% asp and 70% Ryzodeg. So what if we need to add only 1 prandial insulin before lunch? we will find the patient is not compliant to medication, so he will miss this one. He avoid it, use a lot of dose or little dose to control his postprandial, and all the day will not control. Pre-mixed insulin will not help because the pre-mixed insulin need a fixed style daily life. The breakfast steady, and the lunch is steady, and the dinner is steady. This is the profile for pre-mixed conventional or even the pre-mixed analogs. So I think we use this one. This drug is suitable for this situation to Murad. Pre-mixed insulin have a variability glycemic control, have a complete 24-hour basal coverage, need a resuspension technique to be used before use. So what about the IDEG aspart? The IDEG aspart, as I said, 30% short, rapid-acting aspart and long-acting insulin degludec, all of known with 2 molecules. We are use the degludec Treseba. We have a special experience in it in the last 4 to 5 years. And the insulin aspart, the Novorapid, we have a good experience, both of them in one pen, used in some patients. You can use it in some patients. The Ryzodeg profile is rapid acting 30% and basal acting covering more than 24 hours. Of course, we have it till 40 hours the insulin degludec. In step-by-step trial, we use the first R. In this step-by-step trial, we compare our molecule, IDEG, the Ryzodeg, comparing with insulin glargine and +1 ASP, according to 26 weeks in type 2 diabetes, and according to all the known criteria. And then after this 26, we switch. Our domain, we will go for this especially comparison between once daily IDEG aspart comparing with basal insulin and +1 rapid acting insulin. We have this criteria. We have the number of injection. If we compare, this is 1 injection, this is 2 injection. Insulin doses is lower in the Ryzodeg, so we have this reflection into hypoglycemia, and the reflection also on the weight not appear here. The Ryzodeg group weight gain is little bit. A1C reduction are good. Nocturnal hypoglycemia is 45 lesser. And overall hypoglycemia is 10%. This is the same criteria for degludec when compared to glargine in the form of nocturnal hypoglycemia especially. So in Murad, we switch from 30 unit glargine 1-to-1 to Ryzodeg 30 unit. Of course, the basal is different, but that's why we need to use the rapid acting insulin with the basal will help us to have the same rate or maybe a little bit rising in the coming few days when we use our patients. The patient Murad sometimes eat lunch 2 p.m., sometimes eat lunch 6 p.m., sometimes eat lunch in the evening. So in each time, the degludec can cover this. The glargine, you have fixed time. You must give daily in fixed time, but degludec have different, have wide range of you can use it in change of the time. How to treat the dose? Of course, as usual, if you have in the range, you keep the same dose. If you have rising, you can have 2 units. If you have below the range, you reduce 2 units and then build up according to the self-blood glucose monitoring. So Murad will start 30 units of IDEG ASP, prefer or selected for him to be in the breakfast. Why? Because this time is very fixed to him. The breakfast is a well-known time. There is no time for compliance to have or play a role. So if Murad use it, and this is the main meal. Of course, the suhoor is usually not the main meal. Of course, also sometimes our patient eats before prayer Taraweeh and after Taraweeh, and eating all time, so it will cover some of this course. This group of insulin is allowed in children above 2 years. It have approval in adolescents, in elderly above 65, in the hepatic and renal. Of course, renal is the insulin is the best for our patients. What about the advantage of using this molecule in Ramadan? The advantage is you start before and during, and you can keep it after Ramadan. You have single injection usually. This is the usual profile to use it as a single injection. With lower risk of hypoglycemia, require fewer number of injections as we said, recommended to initiate 4 to 6 weeks before to have the time to adjust your patient. Usually all patients in a Muslim country come in the week just before Ramadan announced, and this is very tight for our physician. We usually asking our patient to come early to have the time to control you and reach you the levels that we need. In one of the Ryzodeg Ramadan trial, we compare our molecule by ASP, the insulin analog premixed insulin. A1C control are the same, but usually the core or the secret is the hypoglycemia, which is very important in Ramadan. Nocturnal hypoglycemia 83% significantly lower, day-to-day hypoglycemia 56 significantly lower, overall is 74. So we have this choice to use our patients. We can give the Ryzodeg as part in the iftar and use the Novo Rapid or the ASP alone in the suhoor. So we have premixed insulin Ryzodeg ASP in iftar, and in suhoor we go to ASP, very short acting. Another, we can use the ASP in breakfast, and in the suhoor we can use the Ryzodeg as part. Of course, it's not a common situation, but in some society we can use this. We can use it twice daily. It's not a common practice for us. Sometimes some who against this regimen say, why I use very basal or ultra basal insulin and premix it. I said this is not the usual practice. The usual practice is this molecule is to be given once a day. But if you find in some prescription it's twice daily, it can be done because it's at the end of the day, it's 30-70% complex insulin or premixed insulin. So tackle important challenge of insulin treatment during the Ramadan. Once daily during iftar, this is the best. Of course, the basal insulin, if you use it alone, we use it in Ramadan, in the iftar. We target the most striking postprandial, which is after iftar. So we target the fasting and target the postprandial. All the morning of Ramadan, it will be lesser hypoglycemia and better fasting experience. Thank you.